So I have a business proposition for you. I'm going to say I've got 750 quadrillion bytes of data every day coming into the healthcare world. It's this data from patients and medical records and blood tests and academic literature. 750 quadrillion bytes of data a day. I'd like you to make sense of that as a business model. Who wants to take me up on that? Who's gonna grab that and say, yeah, I can take that and make some sense of it? Anybody? Yeah?
I will.
Oh, you will? Okay. Yeah. So you've actually done this. So you maybe. So this is the idea, is at least some of that. So what I just described is about 30% of the world's data dumping every day is coming through this healthcare world. And so, but this is, you've taken a chunk of this and tried to make sense of it.
Right. So I am at a company called Athena Health, and really what we've focused on is making sense of data in the electronic health record, and very specifically cleaning it up so that then we can use it for research and healthcare optimization tasks in the cancer space. Mm-hmm.
And so how have you done? I mean, how have you taken this data and like, a lot of the stuff is in, it's either comes from electronic health records, which have their own issues. It comes from unstructured data, right?
So the first thing is we had to acknowledge that the data is really, really messy. Right. I mean, when you started off, you were talking about big data. The truth is that the stuff that matters is fairly small but very complex data that needs to be cleaned up and made ready to do research. And so one of the big tasks that we focused on is how do you get it cleaned up? How do you acknowledge that many of the critical data points are embedded deep down in digital paper as opposed to in any digital format that's already analyzable? And so how do you clean it up, and then how do you prepare it to be married to other data sets so that you can make sure that you've got linkable data? Yeah.
And so, and to harness this data, I mean, as Eric Topol, who was here, I hope he's still here, he mentions in this piece, listen, the data's always been there. It's just we haven't really done much with it. It's always been there, all this signal out in the system. Anil, I mean, one of the things that places like IBM Watson are doing is taking all that data and somehow making sense of it through cognitive computing systems, other machine learning applications. So can you talk a little bit about whether you think this is a path that's actually going to shed insights that aren't quantitatively different, but qualitatively different?
Absolutely, it's a great question. So, within IBM Watson Health, our goal is to bring a whole bunch of different partners together who have disparate data, because it's not just about the data, it's what you can actually do by connecting what has typically been silos of data. And then taking those different silos of data, connecting them in a way that makes it so that you're able to understand what they all mean, and then putting analytics and insights through AI, for example, on top of that, so that you're able to get as much value from that data. You're absolutely right. We've been swimming in big data for a while now. I started practicing on an EMR probably back in 1999, and all that data went into our back end, but we weren't really making use of it. We weren't sure which patients were getting sick from the drugs we were giving and which patients were getting better. We had an empirical sense, but we weren't really leveraging it. By combining the data coming out of the electronic health records, putting it in a platform like Watson Health, combining it with claims data, administrative data, to understand the business side of healthcare, we can start asking some really interesting questions about what's really happening. And now with genomics and with wearables and with our environment and the weather, you can start to think about all these different silos of data. If you brought them together, can you start to actually understand what might really be happening that might not be available to us when we're making decisions at the point of care? So absolutely, there's value in it, but it's not about the data. It's what you do with the data, and in terms of making sense of it. And you need a platform that sort of makes that a little bit easier. So we spend the majority of the time figuring out what we want to ask, and the minority of the time cleaning the data up and getting access to it. So with the right kind of platform, you can flip that around and make sure you spend most of your time really understanding what the data is telling you.
So Mona, this brings me to you. I mean, we spend a lot of time in various sessions, conferences like this, bashing the federal government. It's out of habit, I think, for most of us. But the fact is that the federal government has done actually a very good job of parsing data through Medicare data, for example. And a lot of what we understand about public health, we understand from analyzing Medicare claims or looking at usage of services there. Also, what we have in the government is CDC, the Pentagon, which is a massive repository and a longitudinal repository of health data. So you've got this big sandbox to play in. What do you see as the greatest opportunity for us?
So that's right. I think we collect a massive amount of information, whether that is CMS and claims data, whether that's CDC and surveillance data, that's survey data that our behavioral health agencies collect, and HRSA. We collect information around providers and the services and treatment facilities around the country. I think there's been really a significant missed opportunity in how we're connecting that data across the department. So we don't really connect the CMS data with CDC data. In fact, it would surprise, I think, many people to learn that as an external user, you have to go through a data use agreement process with the department. As an internal user, within the different agencies, we have to go through the same process to be able to link data. And so the privacy and security concerns that are there for an external consumer, for me when I was in an academic institution, those are the same challenges that I face in trying to link data across the department. And so there's an incredible missed opportunity there to understand how are we spending our resources, are we making policy decisions that are grounded in evidence. So we're sitting on a massive amount of data, probably unlike any other organization, but are also not leveraging it in any meaningful way yet. And so the journey that we're taking right now is really, it's a 15, 20-year journey, so I'm not saying we're going to transform the department anytime soon, but starting that process of how do you actually take data that provides significant insights into whether it's the opioid epidemic that we're talking about today, whether it's looking at mental health treatment facilities around the country, and how do you actually link that to better understand how we as taxpayers, how our dollars are getting spent in the most effective and efficient way.
Okay, so I take back the really nice thing I said about the federal government, the fact that you guys can't access that data intra-department. But the truth is that there's just so much there with the NIH, with the CDC, as you mentioned, all part of the NIH, but the FDA. There's a lot of important critical data there, and if we can figure out how to do that. So in terms of, let me just follow up on this, because I think this is so important. You do have a new HHS chief. He comes from this sort of world. Tell us a little bit, break some news here. Tell us about some new outlook on data.
You never want to break news.
No, don't break news. Yeah.
I'd say the department actually has been a leader in releasing data sets for public use. I think in the last administration, we released over 1,500 data sets for researchers and entrepreneurs. Right now, the focus is really internally. How are we using those data assets to make better decisions? And you're right, whether it's FDA or NIH or CDC or CMS, everybody wants another agency's data. And our job is to help facilitate that. I don't think people realize that every single part of HHS actually functions within different statutory authorities and different regulations. And so the data is housed within those different authorities. And my job is to try to harmonize that to the extent possible within the existing legislative framework.
Amy, you came from the academic center world, and so you know what it's like not to share. Okay,
now where's this going?
But a lot of this challenge, I mean, obviously there are statutory challenges here, there are regulatory challenges, there's just cultural challenges. Fundamentally, that's really what it comes down to is getting people to understand that, hey, you've got a rich data set here, and we got a rich data set here, and how do we figure this out and coordinate? I mean, tell me a little bit about your experience with that.
I have got experience on both sides of the line. So we've also been thinking about this a lot at Flatiron. And one of the things that I learned along the way is the natural proclivity is not to share, is actually to find lots of reasons to put in place that make sharing really hard, and then point to all of those reasons.
Right.
But what we learned along the way was the best thing you could do was demonstrate the why. If we shared, we can now do the following things. And probably the best example I've got as a contemporary example is at Flatiron, we combine our data set with Foundation Medicine. And you're talking about two large proprietary data sets that have some degree of overlap in individual patients. And when you pull those two data sets together, what you end up with is clinical annotation, the true clinical story that goes along with genomic data. And now you've got a very powerful set or combination. And so once we started to demonstrate what did those two pieces look like together, we could also show other companies, hey, if we could pull data sets together, we can similarly get that kind of synergy. And I honestly believe that part of the problem is there are far too few current and real use cases that say this is the why.
Yeah, I love that. This is the why. But when you think about forming an ecosystem, and so you've got the kernel of an ecosystem. Anil, IBM Watson, one of the things I love about this is that you guys have created an ecosystem of partnerships and trying to reach out to different folks. Tell us where that is, what some of the more surprising relationships are in that data sharing issue, and where we can go from here.
Yeah, I think it's what I'll share with you is within Watson Health we have a value-based care business. And value-based care, for those of you that may not know, is really thinking about the way that providers and hospitals will get paid for value over volume. And for that to really make sense, you got to get the clinical teams to share data with those who are running the business of healthcare, the plans and the payers, including CMS at times, to be able to bring that data together to really understand what the value is occurring. So within our ecosystem, probably the most interesting examples that we're sharing is working. I'll get to where it's not working, but where it's working pretty well is when providers come together with health plans and payers, employers in some cases, patients in some cases, and say, we're going to share data in order for us to all achieve a common goal, which is the best outcomes at the lowest possible cost and avoid all the unnecessary spend. That's working pretty well. Now, I think if the sharing was happening without any problems, we wouldn't be focused as a federal, from a federal point of view on the health IT interoperability. And so I'm fortunate to be a member of this HIT advisory committee where we're trying to make sure that we understand what the people, process, and politics, as well as the technology, may stand in the way of us being able to get at our own data. As patients, we often go around, and I don't know about you guys, but I don't have my medical record on a thumb drive or on my phone. It's scattered throughout all my providers, and we don't have a great way of having all that information be shared. So we do need business models like value-based care to help some of that sharing.
Mona, one of the key problems is interoperability and the difficulty of having so many different systems on so many different standards, so many different names for things. One of my co-chairs, David Agus, loves to say, what are you talking about? We love standards. That's why we have so many of them. And takes a second to think about it. Okay. So, but this has been a challenge, particularly in the federal government. We've tried bioinformatics programs, all with different standards, clinical trials programs, all with different standards. Where are we moving on that?
So this is a huge priority for the department. As you probably saw the announcement from SEMA and from Don Rucker from ONC. I think this issue of interoperability is a huge priority, and there will be a lot of things coming in the future for addressing this. Of course, the federal government can't do it alone, and there have to be changes in the way the market operates, and also consumer demand. I would also actually flip it and say that I think that we also have to talk about the ultimate value of an EHR record right now, which is not a conversation that we're having. I think as
this is the place.
As a physician and seeing sort of the transition from writing my notes as a medical student to now sort of really doing the cut and paste job that many of us are forced to do given the time constraints. I think there is a real conversation to be had around the value of the information that you can get from an EHR record, and that has to get validated over time and really demonstrated, I think, to patients. The other thing I would say is that an EHR record and the data that you're generating from that, to me, the value of it is really determined by the people who are sort of least literate in the medical field, right? And so for those of us in this room, I think we can understand what the value would be. For a person who I see in a free clinic, for me to give them their EHR record and say, okay, run with it and let's figure out the insights from it, that is really not the same value proposition. And understanding what the value of data is to that person and how you move the needle for that person, that should be really the ultimate conversation, not the top 5% that is, that's sort of in this room.
Amy, I know you want to.
Yeah, I'm going to comment on this. I sometimes have to shake it up a little bit. So two things. First of all, you're absolutely right. A lot of the information in the electronic health record is nonsense or cut and paste errors, or at least is represented in digital documents that are otherwise not analyzable. And so one of the core tasks is acknowledging that we've got a data quality problem, and we have to work really hard in a systematic fashion to clean up the quality of the data. The data that we're talking about being aggregated and being put to secondary use, those secondary uses are not going to have value, are not going to be credible unless the underlying data quality problems are solved. And that's not just getting doctors to enter better notes, it's actually doing the hard work of cleaning up the electronic health record data. So I think we need to acknowledge that that's a task at hand and go for it. The second thing is, when you pull together data sets, right, like when we smash them all up, the problem is that smashed up data is just kind of, I always sort of like imagine you're just dumping a whole bunch of stuff in the kitchen soup, and now you've got to figure out how to make sense of it all. And so the nice thing about the electronic health record, when you clean up the data, is it gives you longitudinal context of what happens for an individual patient that forms the backbone upon which you can now put all the rest of your data sets. Because one of the big issues in this whole world of moving towards big data is big data in context is going to be the most important data sets of our future.
Yeah, that's a great point. And I want to come back to the context issue, but I want to make sure that we get some questions from the audience here, from our fellow participants. We have anybody? Any hands shooting up? Okay, well, think about it for a second. I want to get to the context. Amy, I think this is an important point, and please all of you jump in, but that's what's missing from the big data revolution is we just don't have context. We don't connect it to patient histories. We don't have longitudinal data. We don't even know what's changed over time in the same data sets. So it's really hard to figure out when somebody is on a progression that's bad or a progression that's good. We just don't know, and we don't know what we can learn from it. So how do we get the context into that data?
So the number one thing is longitudinality, right? So longitudinal data sets where we're talking about the same individual and what's happened to that individual across time, whether it's in one EHR or merging of multiple data sets where we've put together a set of consistent parts of the story become really important. And I think one of the things that we know as we've been looking at the real-world evidence space is the most important data sets have longitudinality. The other important piece as it relates to longitudinality is then as you link in those other data sets, being able to understand, for example, this is the information about this patient. Here's what happened when we biopsied their tumor. Here's what happened when they treated them. This is what happened to the tumor in response to that treatment, and here's how they did over time. Now you can start to create that set of interrelationships.
Can I also add, I would say it's from a context perspective, data can't solve all the problems, and I think too often we are speaking at a 60,000 foot level and saying, let's put all this data together, we're going to get great insights. I think one of the first steps we have to do is ask the right questions, right? We have to ask the question that is of value to whoever the end user is, whether that's a patient, whether that's the business side of your organization. But I don't think that those conversations often start with what is the value to the end user.
Okay, we've got a question right here. I'd love to, question right there, sorry.
I was just curious if, Kevin Rosofsky, Quanterix, I was curious if you see any companies out there that look like they're on the brink of being able to just amass from birth all the information about what a child goes through, and then as they grow up, they end up the parents have a complete set of records with maybe some recommendations saying, hey, it's time for this vaccine, it's time for this. That it's just an application that just basically manages, like a WebMD for an individual person. Do you see any companies that have that vision that really are trying to just create the ability to just get all the records into one location for the life of someone new if it's hard to go back for someone that already has your medical records all over the place. Do you see anything coming that's just going to start it from scratch?
Good question.
So I sit on the board of directors of Athena Health, which is a cloud-based electronic health record that has everybody from OB to specialty care. I think really, at least in the United States, we're going to need to either have it be the federal government but be able to represent children, or be something like a cloud-based EHR. I'm curious what IBM's run into around the world. I think other governments.
I think the first thing is that what you're describing is not just a sick care system,
Right.
but a wellness, health, and sick care system. And we don't have that really organized, at least not in the US. Plus, I think we have to think about some of the other models that have been tried in this space and ask ourselves whether we have a business model to be able to support something like that. So it's up to all of us who are innovating in this space to create the right business cases and business models, but also start thinking about what does it mean to be healthy and have all this information be in a platform. Yeah. I think the EMR vendors in general are dealing with sick care, and we need to start thinking about, and we certainly are thinking about that at Watson Health.
I would just say that I think the federal government is in a unique place for this, right? So even just within HHS, not only do we have the data that I talked about, whether it's claims or surveillance, but we have data on foster care and youth behavioral health. And we haven't actually just connected it, but it is sitting there waiting for us to start to make use of it beyond the primary purpose.
You know, you're all physicians, and we've mentioned EMRs, EHRs a lot tonight. I mean, and in fact, all through the conference, people have talked about Epic and Cerner. And I don't want to get any of you in trouble, but if we were to imagine an emoji, what kind of emoji would you use to describe Epic or Cerner? You describe it.
I would leave it to that.
All right, great. I mean, but here's the problem. I mean, no one likes these systems. I'll say it. I'll do an emoji. But no one likes the systems, and yet we have this essentially a duopoly. And what are the chances that we can disrupt this duopoly and create something from scratch?
I think there's a long game here. So I think most hospital systems just went through the process of implementing one of these systems. And in healthcare, I think it would take at least another 10 to 15 years before a health system would actually want to invest in doing this again.
I think the EHRs are becoming more like sort of the glass for the physicians. And we all have an opportunity to think about, what does it mean for a clinician or a care team member to be using these systems? How can we inject some insights at the point of care that the EHR vendor may not be able to move quickly enough to innovate? So they are opening up the capability of using interoperability principles like FHIR, and other ways of injecting data and insights. So I'm pretty optimistic that when I still see patients, when I see patients someday in the future, I'll be having innovations and insights that's not being delivered by my EMR vendor, but maybe by others who are innovating.
And I'm going to run around the system and the duopoly. So I believe it's going to be cloud-based infrastructure. I look at organizations like Athena Health, and that's certainly the reason why I've gotten so involved with them. I also, at Flatiron, we own electronic health record in oncology, so we also own a cloud-based EHR. I think what you're going to see is other electronic health records and other parts of the healthcare ecosystem punch holes in the side of Epic and Cerner, and that's going to be the way we do not only data exchange, but infrastructure exchange like apps and other things that help support workflow, et cetera.
Mona, Anil, Amy, thank you so much. Great conversation.
Thank you.
Thank you.